let's talk maintenance a bit, because I think it's there is no established standard. We still have studies with control arms with no treatment in maintenance, so we must accept that we haven't bought a control arm. I, am a capecitabine Bev guy. That's what I do in most of my patients nowadays. I just, why did we ignore the DREAM study? It's a positive study, isn't it? So it's EGF and VEGF. Did we not believe it? Why did we throw the EGF, oral EGF, out at that?
Well, I wouldn't necessarily say that we have thrown it out, but currently we do not have access to the drug, and we have also to admit that the DREAM study had no standard arm in comparison, was an experimental arm either. But I would agree that if we start with a bevacizumab-based treatment, an active maintenance is better than no maintenance treatment, and very likely a moderately dosed fluoropyrimidine or oral fluoropyrimidine plus bevacizumab is the best treatment. I think that's consistent.
In real life,
that's consistent
to my
across all the
patients
trials.
that are treated in first line with chemo plus bevacizumab, what we do, we treat with the full doses of the 3 drugs, labelet plus bevacizumab, as long as it's necessary and clinically relevant. And then usually we take out either oxaliplatin or irinotecan, and we go on with 5-FU or with capecitabine plus bevacizumab, and then we try to keep ongoing. This is what in most, I would say, cancer centers in Italy is done. The problem is that in several small hospitals, for reasons linked to the cost of the drug, to the fact that patients have to come back to the hospital, and so it's a cost for the public health system, maybe treatment is stopped and maintenance is not considered of value, because it's easier to stop everything around 6 months, rather than keep for another 3 or 4 months the patients ongoing. So what I do is not general practice, but in my opinion, bevacizumab data with all clinical trials shows that whenever you treat for longer, the better are the results. And even the ovarian cancer data are in the same direction.
I would like to come back to your question, John, and saying the concept of this combination of biologicals in this situation, highly interesting. For me, maintenance treatment, for today's perspective, we have a standard, which is that what you said. However, for me, maintenance treatment is the field of the experimental development of new drugs, because there we have controlled disease. We have those tumor cells which survive the aggressive induction treatment. Those are those tumor cells which will kill the patient in the end. Yeah? So therefore, I need to understand which cells have survived, which clones have survived the induction treatment, and have these new combinations here. For me, this is the field.
Really exciting.
Maybe
the most do a new biopsy?
Well,
maybe immunotherapy.
We're going to get there.
Maybe immunotherapy, maybe whatever. I even don't call it maintenance treatment.
Switch maintenance, they call it.
In my center, I said it's differentiation treatment. So use the terminology they have in lymphoma or in leukemia treatment.
Well, I think as thought leaders, I think part of the job is for us to declare a control arm, and maybe not care what the regulatory, so if we could agree that maybe CAPE and BEV is the control arm, and then we start putting some stuff on the other side.
Yeah, for
all
sure,
of
for
us would
patients
participate
treated in
in that
first
trial,
line
right?
with bevacizumab.
We'd all jump on that trial.
But if you have a first-line treatment with anti-GFR antibodies,
Fair enough.
You cannot say that anti-GFR plus capecitabine or plus 5-FU is your standard arm.
Totally agree.
There you have still a no treatment or a placebo-controlled arm, unless you want to treat until progression with all the risks.
Totally agree. But that's a subset we could carve out and study in a different way. Let's talk immune.